So shall we start now?
Hello.
Yes, sir.
Yeah, we'll start. Sure.
Yes, sir. So good evening, everyone. Welcome to this session of Eye and Knowledge series. I am Dr. Nirmal Kumar Gautam, DNB first year resident at Manipal Hospital, Bangalore. And the session will be moderated by Dr. Venkatesh H A. Sir is a senior neonatologist and consultant at Manipal Hospital, Bangalore. So the topic for today's discussion is short bowel syndrome. And first we'll be discussing a case and then in detail about short bowel syndrome. I hope I am audible, sir.
Yeah.
Yes,
Perfect.
so I'll be starting the sessions.
Yes.
Yeah, so it was a female baby born at the preterm gestation of 32 weeks and 2 days with a birth weight of 2.17 kg. Baby was born to a G3P1L1A1 mother by emergency LSCS, indication being bleeding PV because of the placenta percreta. So as we can see in the picture, it's a part of the placenta accreta syndrome. In accreta, generally we see the placental invasion till the endometrium, and in the increta it goes beyond the endometrium into the myometrium, and in the cases of percreta, which is very rare, 5% of the times, it can go beyond the uterine wall and sometimes can involve the adjoining organs. In this case, the adjoining organ involved was a bladder, urinary bladder. So the baby was born at limp at birth and required positive pressure ventilation for 2 minutes, followed by intubation. And spontaneous breathing efforts could appear only by 5 minutes, and the baby was pretty active. They extubated at 14 minutes. We were shifted to an ICU on CPAP support, and we could get a cord blood gas, venous blood gas, which was showing a pH of 7.3, PCO2 of 40.8, bicarb of 20.7, base excess of -6, and lactate of 2.3. So the baby was shifted to an ICU and started a ventilator CPAP with a PEEP of 6 and FiO2 requirement of initially 40%. Chest X-ray was done, which was suggestive of mild RDS changes. So started on IV fluid and empirical first-line antibiotics. In urine, we start with ampicillin, netilmycin. Injection caffeine loading was given, and trophic feeds 1 ml 6 hourly were started with preterm formula as the mother was very sick and EBM was not available. So mother had to go under a hysterectomy and bladder reconstruction and was ventilated in the MICU. So gradually we see saw that the baby was needing FiO2 up to 50% the CPAP and was intubated at 24 hours and surfactant Curacao was given. So SIV was continued and FiO2 requirement came gradually to 25%. Baby was extubated to CPAP at 46 hours with a PEEP of 6 and FiO2 requirement of 25%, and gradually feeding was started. and IV fluid was stopped on day 4, and OG feeds were at a considerable volume of 100 ml per kg per day. So on day 4, baby again had intermittent desaturations and tachycardia, requiring increased FiO2 up to the 40%. And there was an hyperglycemia, and sepsis screen was sent. IV antibiotics were upgraded to meropenem and amikacin, and metrogyl was added as per pediatric surgery advice, suspecting NEC. An X-ray chest and abdomen was done, which showed normal lung fields, but gaseous distension of the bowel. So baby was kept entry and shifted to the isolation room. Abdominal distension and brownish gastric aspirate followed, and baby was intubated as baby was sicker. Baby was started on SIMV with minimal settings of 18/5, 30% of FiO2 and rate of 45. And vasopressure dobutamine at 5 mic per kg per minute was started in pure 4 per kg. So the repeat X-ray showed gaseous distension of the bowel loops, like this one. And the blood sugars again went very high. 543 was managed with the insulin infusion of 1 dose. And again, dopamine had to be started because the baby was still hypotensive, mean BP being 30 millimeter of Hg. USC and UVC was put in situ, and invasive BP monitoring was started. IV fluid was changed to dextrose 10% plus normal as per the electrolyte status. Abdomen was further distended and tender, and OG aspirates volume was increased, which was obviously greenish in color, and baby was kept, although the baby kept passing meconium. PRBC was transfused at HB was 12, and the baby was in shock and required high FiO2. So repeat X-ray on day 5 was done, which was suggestive of perforation and free gas in the abdomen. So this was the X-ray, and after this X-ray, it was you can see almost free gas lying inside the abdomen like a football sign. So the baby was done a emergency peritoneal glove drainage, which was performed with the pediatric surgeon on call immediately. And FFP was transfused as the PTT were deranged. And on day 6, the baby had to be operated, and platelet further dropped to 4,000, and SGB transfusion was given prior to shifting for exploratory laparotomy. Baby required very high FiO2, and just X-ray done before shifting was suggestive of worsening of the lung fields, and shifted to HFOV with a map of 20, delta P of 34, 10 frequency, and FiO2 requiring up to 100%. Baby was shifted to OT, and surgery was done while the baby was on HFOV ventilation and on 2 inodrops. It had a very stormy course and required 2 SDPs, 2 FFP, and 3 BRBC transfusion on the operative day. So the intra findings were bowel perforation in the ileum along with the necrosis and multiple necrotic patches noted in the jejunum. This was the intra-uterine picture you could get. In the first picture, you can see this was the part of the ileum which was necrosed, and then we had part of the jejunum which was also necrosed in patches. So the surgeons decided to do an jejunostomy, proximal and distal, and a distal ileum and ascending colon was also brought as a stoma to preserve the bowel as much as possible. So this was the stomas done. We can see from left side of the baby to the right side. So it was a proximal jejunal stoma created here, and then just beside that distal jejunal stoma, and there was an ileal stoma, and then ascending colon was open because the IC valve was removed. So the complications were too much after the post-surgical time. Baby had hypoalbuminemia, acute renal failure, hyperkalemia, hypokalemia, hyponatremia, and disseminated intravascular coagulopathy. All the complications were managed, and post-op pain and sedation was managed with fentanyl infusion and paracetamol infusions. Inodrops were stopped after 48 hours of surgery, and post-op parenteral nutrition, aminoven, and smog-lipid was started through the PICC line. So continuous OG spirits were quantified and replaced, and open ostomy care started with the regular monitoring of the ooze and leak initially from the ostomas. HFOV ventilation continued till 4 days post-op, and then the baby was shifted to SIMV. Finally, baby could be shifted to CPAP on the post-op day 7, and trophic feeds were started by that time. And this time EBM was available as mother had recovered, and we started giving EBM to the baby. So gradual increment in feeds were done, like 1 ml every 4 hourly, and ostomy care was continued with the cold blast barrier cream application over the skin around the stomach. So challenges at this point of time was to reach full volume feeds for the baby, and as all the feeds were coming out of the jejunostomy as losses, so it was a very difficult situation because hardly any nutrition was going on beyond the jejunum. And care of the stomas and skin over the abdomen was a concern. And future implications as the IC well was lost. So further course, baby reached a considerable volume of the enteral nutrition by UG feeds on day 18 of life, and parental nutrition was continued. Dye study was done under fluoroscopy on day 28 to decide on the refeeding through the distal stomas, which was suggestive of an enteric fistula, unfortunately, and which caused leak of the dye over the skin near the suture line. So baby had to be re-explored after discussion with parents on day 33 of life, and that intraoperation fistula was removed, ileal and colonic stomas closure were done as the bowel was healthy inside, and gymnosperms were left for future closure. So this was the post-op picture after the second exploratory laparotomy. You can see in the diagram, the previous two stomas were closed, the ileostomy and the ascending colostomy, and the gymnosperms were left in place. And this is the refeeding tube later, which was put for refeeding. So another repeat. Sorry. Another repeat dye study was done 1 week after the closure of the ileal and colonic stoma through the distal jejunal stoma. And luckily, this time we could see the dye passing from the distal jejunum till the rectum in serial order. So refeeding was started through the distal jejunal stoma, which baby tolerated well and started passing stool per rectum too. And parenteral nutrition has been now stopped by day 44 of life. Baby has started taking direct oral feeds and breastfeeds, and refeeding has been continued. But the baby has developed cholestasis, that direct bilirubin being 3 mg per dl during the course, and is being managed with the supplements A, D, E, and vitamin K and UDC. So we'll now discuss about short bowel syndrome. Is there anything to discuss at this point?
Yeah, that's true. But what the stormy course indicates two aspect of it. One is the sickness on one side, and the mother actually is sick, baby is sick, and if you look at the father who was alone actually taking care of both,
Yes,
and so this is very very important in our country, especially. You have to balance the money, you have to balance the pair, the sickness in both the wife and the baby, and so this is. Unfortunately, in our country, you'll not most of the parents what they say that when mother is so sick, they say that better we just make sure that mother comes out. We don't want baby. That's what we see most of the times in our clinical
yes,
practice. But in this case, actually, father was so strong enough to say that, and I think he was positive enough to say that he wanted both the sides actually, the survival. And
yes,
that's how I think. And luckily, with this, actually, mother improved and she started coming to NICU, and she looks very, in the sense, very happy looking at the baby. So, this is the counseling and the acceptance from the father, and no other members are there actually to support him. What we
yes,
see
sir.
from day one till now, I've not seen anybody else coming to the unit. Correct, Nirmal?
Right, sir.
It's only the father
Yeah, he is
and
the
mother
only one who is doing everything.
only. So then that's what, and yeah, this is what exactly we need to see how patients will help. Of course, the finance is always the backbone of the whole thing. Yeah,
Yes,
that's good, Nirmal.
yes.
Yeah,
So
I agree with
I would
you.
like to invite any questions at this point of time.
Yeah,
Then we'll
yeah,
move
yeah.
with the discussion about short bowel syndrome.
Anybody has any doubt?
Or any queries regarding the case. I think so. We'll discuss at the end again. So we'll
Yeah,
start with the present
yeah,
short bowel syndrome
yeah,
topics.
yeah, sure.
So definitions are very important as far as short bowel syndrome and intestinal failure is concerned. So there had been many definitions given in many publications, but these have been selected regarding these looked very feasible. So intestinal failure has been defined as significant reduction in the functional gut mass below critical threshold necessary to maintain growth, hydration, and electrolyte balance. And intestinal failure also can occur because of surgical resection of bowel. It can also be because of congenital anomalies or functional or motility disorders. And the short bowel syndrome is like need for prolonged parenteral nutrition following bowel resection, usually for more than 3 months. There have been many definitions regarding SBS, but most of them are dependent on the duration of parental nutrition. So the epidemiology, the incidence of SBS in the NICU from a single center study had been reported as 22 per thousand NICU admissions and 24.5 per 1 lakh live births. And premature infants have much higher incidence of admissions as compared to term infants per thousand NICU admissions. It was data given by Wales et al. Published in Journal Pediatric Surgery in 2004. Another multi-center series reported an incidence of 7 per thousand among VLBW infants and 10 among term babies. The etiology of the SBS in neonates and young infants. So most commonly, if we see in our scenario, this NEC is the common cause of SBS, that is leading up to 35%, and then intestinal atresia 25%, 18% by gastroparesis, and 14% by malrotation and valvulus, and sometimes with less common conditions like Hirschsprung disease with proximal extension of aganglionosis in the small bowel. In very low birth weight infants, NEC remains the predominant cause of short bowel syndrome. And in the NICSG cohort, 96% of the cases of SBS were due to the NEC. And the congenital defects like gastroparesis, intestinal atresia accounted for 2%, and valvulus accounted for remaining 2% of the cases. Coming up, some disturbance, I'll mute that person.
Yeah, some disturbances.
Yes. So in the clinical presentation of infants with SBS, so it has been divided into 3 stages. Stage 1 acute phase, stage 2 recovery phase, and then the maintenance phase. So stage 1, after recovery from the post-op ILS, acute phase starts about 1 week after the surgery and lasts up to 3 weeks. And there is a large fluid and electrolyte losses in ostomy and in form of effluent and stools, and intravenous fluid and parenteral nutrition is required. So depending on the extent of intestinal resection, it's associated with the mostly gastric hypersecretion, and S2 blockers or PPIs can be required in this stage. In the stage 2, that is recovery phase, it starts after a few weeks and continues for several months, and there is a gradual improvement in diarrhea and ostomy output, and dependence on parenteral nutrition can be there. Depends on degree of initial intestinal loss, condition of the remaining bowel at the time of the surgery, and then compensatory histoarchitectural changes in the residual gut mucosa. The clinical management during this stage involves cautious initiation and enteral nutrition. And then the stage 3, that is maintenance phase. The third stage indicates successful intestinal adaptation. In this stage, enteral nutrition is tolerated and parenteral nutrition can be discontinued. Oral feeding can often be started at this stage, and the time required to reach this stage is variable depending on the infant's clinical course and complications. So there's a term called intestinal adaptation. So it's basically the recovery of intestinal function after the intestinal resection, and it starts around as early as 48 hours after surgery and may continue up to 18 months. This intestinal adaptation has been interchangeably used with the term intestinal rehabilitation. So typical rehabilitative changes which occur in the mucosa are axial lengthening of the villi, deepening of the crypts, and increased introcyte proliferation, increased enterocyte counts per villus, and enhanced enterocyte function with increased nutrient uptake. So the length of the intestine is arguably the most important determinant of the clinical outcome in SBS. So the intestinal length increases from around 142 plus minus 22 centimeter at 19 to 27 weeks of gestation, and around 217 plus minus 24 centimeter at 27 to 35 weeks, and then 300 centimeter plus minus 44 centimeter at term. So the range being from 176 to 305 centimeters. And the small bowel growth peaks at around 25 to 35 weeks gestation, and then doubles in length during the last 15 weeks of the pregnancy. So after birth, the intestine continues to grow at a rapid rate until the crown heel length reaches 60 centimeter, and then at a slightly slower pace until the mature intestinal length of 600 to 700 centimeter is reached, about when the somatic height approaches nearly 100 to 140 centimeters. So there have been various studies with length as a determinant for outcome of SBS. In the absence of surgical bowel lengthening and tapering procedures, an infant with about 35 centimeter of residual small bowel had a 50% probability of being weaned from parenteral nutrition as per Androsky DG et al. And the likelihood of developing SBS following bowel resection was greater when the residual intestinal length was less than 25 centimeter of the predicted length for given gestational age. In another study by Wilmer, he reported an infant with SBS was more likely to survive if the small intestinal length was at least 15 centimeter in the presence of intact ileocecal valve or 40 centimeter in the absence of ileocecal valve. So, consistent with these observations, there was another study by Spencer and colleagues who noted that a bowel length of less than 10% of expected length was associated with increased mortality, the relative risk being 5.7. And with a given intestinal length, the outcomes may also vary depending on the quality of the remaining bowel, region of the GIT, and the gestational age of the patient. So there are reports of some infants who have been successfully from parental nutrition with as little as 10 centimeter residual intestinal length. So generally, the premature infants have a greater capacity for intestinal growth and adaptation as compared to full newborns. So these is a diagram depicting the intestinal sites of nutrient absorption. We see from top to down. You can see the stomach and duodenum are the main organs responsible for the mineral absorption, being it calcium, iron, or other minerals. And amino acids, small peptides, monosaccharides, fatty acids, fat soluble vitamins A, E, D, K is mostly absorbed from duodenum and jejunal areas. Disaccharides exclusively gets more absorbed from jejunal area, and water soluble vitamins zinc is absorbed from jejunum and ileal part. If you see, the bile salts are mostly absorbed from ileum, and while water and sodium absorbed from mostly throughout the GIT. So what happens when the particular segment of GIT is resected? So in this diagram, we can see jejunal resection. In the jejunal resection, there will be decreased cholecystokinine, secretin, vasoactive intestinal polypeptides, and serotonin all will be decreased, which causes gastric hypersecretion. And while in the ileocecal valve resection, there will be more overgrowth of colonic bacteria in the small intestine. And if you see for the ileal resection, there is a decreased intestinal transit time, steatorrhea, and vitamin B12 malabsorption. So secretory diarrhea can and renal oxalate stones can be a problem. In the colonic resection, generally there is a decreased YY peptide secretion. So other predictive factors than length are for the outcome of SBS are intact ileocecal valve, serum citrulline level, absence of small intestinal stoma, and the lack of bowel dilation and the diagnosis of NEC itself. So if we see about citrulline, there have been several studies which have shown that the plasma level of citrulline, which is a non-structural amino acid and synthesized in the intestinal mucosa, is a useful marker of estimating the total functional intestinal mass. So serum citrulline concentrations have correlated with the length of the remaining small intestinal bowel in patient with SBS, and also with the ability of the patient to be weaned from parenteral nutrition. And there's another study from Rhodes and colleagues which showed that the serum citrulline level showed a linear correlation with the percentage of internal calories and bowel length. So he said that serum citrulline level of more than 19 millimole per liter was associated with internal tolerance and was predictive of weaning from parenteral nutrition. And in another study by Fitzgibbons and colleagues showed that patient with plasma level of citrulline less than 12 could not be weaned from parenteral nutrition. Sorry, there's some disturbance. So morbidity and mortality of the SBS. So infants with SBS are at more risk of sepsis, prolonged hospitalization, growth delay, and motor developmental delay. So infants with SBS have a threefold increase in mortality than the controls who had the same underlying condition but no SBS. So infants with SBS have disease-specific rates of mortality that are 5 times higher than those without SBS. And SBS related mortality tends to be highest in the early postoperative period and then decreases until 200 to 350 days after surgery, when a second peak in mortality is associated with the onset of end-stage liver disease. I will be discussing about complications of the short bowel syndrome. First of there is a gastric acid hypersecretion. It can occur in about 50% of patients, and it's more seen in proximal intestinal resection, mostly jejunal resections. And this predisposes to acid peptic injury, exacerbates fluid and electrolyte losses, and impairs the intraluminal digestion. It can cause malabsorption by causing inactivation of the pancreatic exocrine enzymes, precipitation of the bile salts by ineffective micelle formation, and physical damage to the small bowel mucosa. So there can be increased circulating levels of gastrin, which is the primary reason for the acid hypersecretion. Another complication is bacterial overgrowth, can be found in 60% of the patients and result in deconjugation of bile acids, competition for metabolites, consumption of internal nutrients and vitamins, accumulation of toxic metabolites such as D-lactate, and bacterial translocation producing bloodstream infections. So clinical signs of bacterial overgrowth will include abdominal pain, vomiting, diarrhea, and metabolic acidosis. Another complication is translocation of enteric bacteria, which can happen to bloodstream and is an important complication of short bowel syndrome with bacterial overgrowth. In animal models, it has been seen that aerobic bacteria is translocated more readily than the anaerobic bacteria. And the treatment will be empiric, like broad spectrum antibiotics, which is effective against the enteric bacteria, administered for 7 to 14 days, followed by rest for 14 to 21 days, and then the cycle is repeated. The other important complication of short bowel syndrome being central line associated bloodstream infection, that is CLAPSIS. Because if the line is in place, it's a needus for infection and bacterial translocation. These patients increases the risk. The frequency being 11 to 26 infections per 1,000 catheter days, and clinical signs will be like fever, irritability, and ileus. So catheter-related infections have been minimized by use of antibiotic impregnated catheters and antibiotic or ethanol locks. In a study by Jones and colleagues, reported successful use of 70% volume by volume ethanol locks in 23 patients with SBS. Ethanol locks were well tolerated with no reported adverse effects, and the rate of infection decreased from 9.9 per thousand catheter days in historical controls to 2.2 per thousand catheter days during the period when ethanol locks were used. And another complication is intestinal failure associated liver disease, that is called IFALT. In 40 to 60% of infants who require long-term parenteral nutrition for intestinal failure, it can occur. And the clinical spectrum includes from hepatic steatosis to cholestasis to cholelithiasis and sometimes hepatic fibrosis too. So liver disease can present as biliary cirrhosis and portal hypertension in minority of the patients. Pathogenesis being very multifactorial, and in infants, the risk increased with prematurity, low birth weight, duration of the parenteral nutrition, recurrent sepsis, and multiple laparotomy. In patients with no enteral feeding, decreased gut hormone secretion can cause biliary stasis and the development of biliary sludge and gallstones, which can further impair hepatic dysfunction. And the deficiency of taurine, cysteine, and choline may also contribute to liver toxicity. So conventional parenteral lipid solutions containing sunflower oil may also contribute to liver toxicity in these patients. And in short bowel syndrome, the liver disease usually presents with increasing jaundice, scleral icterus, hepatosplenomegaly, elevated serum transaminases, and eventually portal hypertension. Monitoring of the liver function is an essential in the management of IFLD, and the liver biopsy is the gold standard to assess the extent of the liver damage. Duro et al. Reported a non-invasive C13 methionine blood test to differentiate cirrhotic versus non-cirrhotic patients. Now we come to management of the short bowel syndrome. So it requires a multidisciplinary approach involving the neonatologists, gastroenterologists, surgeons, nutritionists, pharmacists, nurses, and the social workers too. So a cohesive and integrated multidisciplinary approach has been shown to increase the rate of survival in children with short bowel syndrome. The aim of clinical management in SPS should be to provide sufficient nutrition to facilitate growth, minimize fluid and nutritional electrolyte losses, and then we come to specific components of the management, sir. So we'll be discussing now about the parenteral nutrition. So it provides adequate caloric intake, macronutrients and micronutrients to optimize growth and development. Careful attention should be paid to protein intake per se to prevent catabolism, and some patients may need up to 3.5 gram per kg per day. An ideal PN macronutrient needs to be needed for the VLBW provides 90 to 100 kilocalorie per kg per day, 4 gram of amino acids per kilogram per day, and 2.5 to 3 gram fat per kg per day. This was a recommendation by Aspen Pediatric Nutrition Support Curriculum in 2015. The restricting carbohydrates in the immediate perioperative period, as many patients with SBS are unable to use these calories optimally during this period of stress, is important. So to ensure optimal total caloric intake, fats comprise a critical part of the parenteral nutrition. However, there is an increasing concern that the cumulative amount of lipid in parenteral nutrition in patients with SBS is an independent risk factor for the development of cholestasis. The current lipid formulations are mostly based on soybean lipids, olive oil lipids, or fish oil lipids. So limiting soy lipid-based formulations to less than 0.5 gram per kg per day has been shown to delay or even prevent cholestasis. About 50% of the fatty acids present in the soy-based formulations are omega-6 polyunsaturated fatty acids, such as linoleic acid, which is a cause of concern because linoleic acid has been known as an immunosuppressive and having pro-inflammatory effects. And IV lipids derived from soybean oil emulsions are also considered the primary reason for cholestasis because of the effect of raising serum phytosterol concentration, which suppresses the bile flow, and obviously providing omega-6 fatty acids too. And soy lipid formulations have been linked to impaired glucose homeostasis, where gluconeogenesis was increased, but the normal reduction in glycogenolysis was inhibited. So fish oil-based formulations such as omega-1, which are rich in omega-3 fatty acids, have been shown to reverse the parenteral nutrition-associated cholestasis. And infants on fish oil lipids showed reversal of cholestasis at 9.4 weeks compared with 44.1 weeks in a historical cohort taking soy lipids and also had lower mortality. So administration of fish oil lipids was not associated with fatty acid deficiency, hypertriglyceridemia, infection, or growth delay. There have been a talk about olive oil based parenteral nutrition formulas as well, and it has been shown to be safe and well tolerated in infants. Compared to the soy lipid formulations, olive oil based lipids contain lower level of linoleic acid, thereby avoiding the adverse effects associated with soy oils. And olive oil based formulations can also decrease total cholesterol and low density lipoproteins with no significant difference in the liver function. So Gupta et al. In a study found that the limiting IV dextrose to a glucose infusion rate of 9.3 milligram of carbohydrate per kg per minute in premature infants may be helpful in decreasing the incidence of parenteral nutrition associated cholestasis. And methionine in excess from the PN amino acids is also implicated in the development of exacerbation of PNS. So infants with ileostomy or poor colonic function can lose considerable amount of sodium in the stool, which is important to consider. And in the absence of adequate sodium replacement, compensatory hyperaldosteronism may ensue and result in increased urinary potassium loss. Generally, parenteral sodium replacement is considered adequate if the level of urinary sodium are greater than 30 milliequivalent per liter. Now, the trace elements depletion is not unusual in patients with SBS on parenteral nutrition, and zinc is of particular importance in infants with extensive intestinal reception, as substantial amount of zinc could be lost in ileostomy fluid, as high as 17 mg per liter of ileostomy fluid. And infants with SBS who are dependent on parenteral nutrition often require 300 to 500 milligram per kg per day of zinc. So now we talk about enteral nutrition. So little agreement is there in the literature regarding the timing of initiation or the rate of advancement of the enteral feeding in SBS. Most clinicians would prefer to start enteral feeding as soon as possible, hoping to promote intestinal adaptation, achieve full enteral feed sooner, and prevent parenteral nutrition associated adverse events. So continuous administration of enteral nutrition is the preferred method because of a lower risk of osmotic diarrhea and an overall better tolerance than the bolus feeds, which was suggested by Vanderhoof et al. In SBS, continuous feeds optimize absorption and probably adaptation by permitting the total saturation of the transporters in the gut for 24 hours a day. And the refeeding intraostomy output through mucus fistula has been shown to facilitate improved growth and improved EN tolerance after the bowel has been reconnected. Now, if we talk about the optimal formula of the enteral feeds, it has not been yet established, and most clinicians prefer human milk or a semi-indulgent or amino acid-based formula containing MCT oil and long-chain triglycerides. In an experimental model, formulation containing complex proteins, disaccharides, and long-chain triglycerides increase the intestinal adaptation, but concerns remain about the increased gut permeability to complex protein and the risk of sensitization. So human breast milk is associated with the shorter duration of parenteral nutrition when compared with cow's milk or protein hydrolysates. The difference between hydrolyzed protein and non-hydrolyzed protein has been evaluated in infants receiving some enteral and parenteral nutrition, and no difference was noted in energy intake, intestinal permeability, or nitrogen balance. And finally, if all the other formulas and feeding strategies fail, then free amino acid formula has been associated with shorter duration of PN, decreased risk of developing food allergy, and generally well tolerated despite their higher osmolarity. So formulas with 40% of its total fat from MCTs are preferred due to an ease of absorption directly into the portal system without the need of bile acid and muscles. Increased absorption and retention of fat leads to improved weight gain and growth, and fatty acid metabolized to short chains have been shown to have trophic effects and aid with adaptation and absorption of both the small bowel and colon. So the PUFA intake, especially DHA and arachidonic acid, is strongly correlated with positive cognitive effects in the